Managing a difficult VT storm, that is defined as 3 or more distinct episodes of sustained ventricular tachycardia or ventricular fibrillation within 24 hours, requires a rapid stepwise escalation from stabilization to advanced structural and autonomic interventions. Primary goal of initial management, that is calming the storm, is to break the cycle of sympathetic overdrive that perpetuates the arrhythmia. Non-selective beta blockers like propranolol intravenously are superior to cardioselective ones because they block peripheral beta 2 receptors, reducing the systemic catecholamine surge. Propranolol has a membrane stabilizing local anesthetic-like effect. Incessant shocks cause significant pain and anxiety, further fueling the adrenergic storm. Early intubation and sedation are often necessary to reset the autonomic system. Amiodarone is still the first-line choice, bolus followed by infusion. Lignocaine may be effective in ischemic settings. Procainamide is preferred for stable monomorphic ventricular tachycardia in the absence of severe heart failure. Triggers have to be identified and reversed. Correcting hypokalemia and hypomagnesemia is mandatory. We know that hypokalemia will be refractory if associated hypomagnesemia is not corrected. If the patient continues to experience ventricular tachycardia despite deep sedation and dual or triple antiarrhythmic drug therapy, escalation must happen within hours, not days. Mechanical circulatory support is considered in case of hemodynamic instability, that is SCI, Society for Cardiovascular Angiography and Interventions, shock stage C to E. In refractory ventricular tachycardia despite medical therapy, or to provide stability during high-risk catheter ablation. Options are Impella, which unloads the left ventricle and maintains endogam perfusion during incessant ventricular tachycardia, or ventricular arterial ECMO, extracorporeal membrane oxygenation, provides full circulatory support and respiratory support, often used as a bridge to ablation or bridge to transplant. Indication for an urgent catheter ablation is refractory monomorphic ventricular tachycardia. Early ablation is now considered class 1 recommendation in most guidelines for storm refractory to antiarrhythmic drug therapy. Recent data show that ablation reduces 1-year mortality from 40% to 20% in high-risk populations. When rhythm-based drugs fail, targeting the nervous system is the next difficult management step. Stellate ganglion block, a bedside ultrasound-guided injection of local anesthetic into the left or bilateral stellate ganglia, can be done within the premises of the intensive care unit. It can provide immediate albeit temporary suppression of ventricular tachycardia. Effect can be maintained by putting in a cannula and continuing the infusion for a longer period. Cardiac sympathetic denervation is a surgical procedure typically done with video-assisted thoracoscopy involving the removal of lower half of the stellate ganglion and T2 to 4 ganglia, that is thoracic ganglia, upper thoracic. It is a highly effective bailout for refractory cases. An emerging palliative option is stereotactic body radiation therapy, that is using the radiotherapy machine and not in the cath lab or ablation lab, for patients too unstable for a 6-hour catheter procedure. Non-invasive radio ablation that can be delivered in 15 to 40 minutes It's currently used under compassionate use protocols for most difficult refractory cases. Here is a summary decision algorithm for escalation. Incessant shocks and anxiety, intubation and general anesthesia may help. Hemodynamic collapse or shock, impella or ventricular arterial ECMO can help. Refractory monomorphic ventricular tachycardia, take up for urgent catheter ablation. Failed ablation or incessant VT, stellate ganglion block can be considered. Or you can have cardiac sympathetic denervation by VATS, that is video assisted thoracoscopic surgery. For a failing heart with refractory ventricular tachycardia, evaluation for heart transplant or ventricular assist devices.